Pharmacological LDL cholesterol lowering therapy. In this session, we will discuss pharmacological LDL cholesterol lowering therapy, with a particular focus on statins, which remain the cornerstone and first-line treatment for LDL cholesterol reduction. Understanding how and when to use statins is essential, because LDL cholesterol reduction is one of the most effective strategies for preventing cardiovascular events. Let's begin with the mechanism of action. Statins inhibit the enzyme HMG-CoA reductase, which is the rate-limiting enzyme in hepatic cholesterol synthesis. When cholesterol production in the liver decreases, hepatocytes increase the expression of LDL receptors on their surface. These receptors remove more LDL particles from the circulation, leading to a significant reduction in LDL cholesterol levels. The major effect of statins is LDL cholesterol reduction. They also produce a modest reduction in triglycerides and a mild increase in HDL cholesterol. Now let's discuss the different types of statins. Statins can broadly be classified into lipophilic and hydrophilic agents. Lipophilic statins include simvastatin, lovastatin, atorvastatin, and fluvastatin. Because they are lipid-soluble, they can enter many tissues through passive diffusion, including skeletal muscle. As a result, they are generally associated with a higher risk of muscle-related adverse effects and more drug interactions through the cycloprom P450 system. Hydrophilic statins include pravastatin and rosuvastatin. These agents are more hepatoselective and generally have fewer drug interactions. In clinical practice, statins are classified according to their LDL lowering potency. Low-intensity statins reduce LDL cholesterol by less than 30%. Moderate-intensity statins reduce LDL cholesterol by approximately 30 to 50%. High-intensity statins reduce LDL cholesterol by more than 50%. The two most commonly used high-intensity regimens are atorvastatin 40 to 80 milligrams daily and rosuvastatin 20 to 40 milligrams daily. The next important question is, when should we use high-intensity statin therapy? The first major indication is established atherosclerotic cardiovascular disease. This includes patients with previous myocardial infarction, coronary artery disease, peripheral arterial disease, ischemic stroke, or transient ischemic attack. These patients should receive high-intensity statin therapy, irrespective of their baseline LDL cholesterol level, provided the treatment is tolerated. The second indication is severe hypercholesterolemia, particularly patients with LDL cholesterol of 190 milligrams per deciliter or higher, or those with familial hypercholesterolemia. A third group includes patients who have a high calculated cardiovascular risk. Current ACC/AHA guidelines generally favor high-intensity statin therapy when the 10-year ASCVD risk exceeds 10%. However, in everyday practice, many clinicians start with a moderate intensity statin, especially when concerns exist regarding tolerability. After initiating statin therapy, appropriate monitoring is important. LDL cholesterol should be rechecked approximately 6 to 12 weeks after starting treatment or after a dose adjustment. At follow-up visits, assess medication adherence and reinforce lifestyle interventions, including dietary modification, exercise, and weight management. Baseline liver function tests should be obtained before starting therapy. However, routine monitoring of liver enzymes or creatine kinase is not required in asymptomatic patients. Once LDL targets have been achieved, an annual lipid profile is usually sufficient. Now let's review the adverse effects of statins. The most common adverse effect is myalgia, which refers to muscle aches without a significant elevation in creatine kinase. Myopathy is characterized by muscle weakness associated with elevated CK levels. The most serious muscle complication is rhabdomyolysis, which involves extensive muscle breakdown leading to marked CK elevation, myoglobinuria, and potentially acute kidney injury. Other adverse effects include mild elevations in liver enzymes, gastrointestinal symptoms such as nausea and dyspepsia, and rarely headache or sleep disturbances. Several factors increase the risk of statin-associated muscle toxicity. Hypothyroidism is one of the most important and commonly overlooked causes. Drug interactions involving CYP3A4 inhibitors can substantially increase statin concentrations. Other medications associated with increased muscle toxicity include fibrates, colchicine, and cyclosporine. If a patient develops rhabdomyolysis, statin therapy should be discontinued immediately. This recommendation applies whether symptoms are present or not when CK levels exceed 10 times the upper limit of normal. Patients should be encouraged to maintain aggressive hydration to facilitate renal excretion of myoglobin and reduce the risk of kidney injury. Patients with a history of statin-induced rhabdomyolysis should generally not be rechallenged with another statin because recurrence can occur. More commonly, clinicians encounter patients with muscle aches or weakness rather than true rhabdomyolysis. In these patients, the SAM-CI score can help estimate the likelihood that symptoms are truly related to statin therapy. For patients with a low SAM-CI score, discontinue the statin temporarily and investigate alternative causes, such as concomitant medications, musculoskeletal disorders, or psychological factors. Once symptoms resolve, consider restarting the same statin at a lower dose or switching to another statin. If symptoms recur, agents such as pravastatin, fluvastatin, or pitavastatin may be better tolerated. Alternate day dosing can also be considered. For patients with a high SAM-CI score, discontinue the statin and evaluate for reversible contributing factors such as hypothyroidism, vitamin D deficiency, renal disease, hepatic disease, or significant drug interruptions before considering reintroduction. Let's now discuss liver dysfunction. Mild asymptomatic elevations in transaminases less than 3 times the upper limit of normal do not usually require discontinuation. Continue therapy and repeat liver function testing. If liver enzymes remain persistently elevated above 3 times the upper limit of normal, or if the patient develops symptoms suggestive of hepatitis, such as jaundice, fatigue, or right upper quadrant pain, stop the statin and investigate other possible causes. Once liver tests normalize, a lower dose or an alternative statin such as pravastatin or rosuvastatin, or alternate day dosing can often be tried successfully. Severe statin-induced liver injury is extremely rare. In such cases, permanent discontinuation is appropriate. Drug interactions are clinically important and frequently tested in examinations. Verapamil and diltiazem can increase simvastatin concentrations. HIV protease inhibitors are generally contraindicated with simvastatin and lovastatin. Amiodarone increases the risk of statin-associated rhabdomyolysis. Large amounts of grapefruit juice can substantially increase statin exposure. Cyclosporine markedly increases the risk of statin toxicity. Among fibrates, fenofibrate is generally safer than gemfibrozil when combined with statins. Special populations require additional considerations. In severe chronic kidney disease, atorvastatin and fluvastatin are often preferred because they require less dose adjustment. Most other statins require dose reduction in advanced renal impairment. In chronic liver disease, pravastatin and rosuvastatin are often preferred because of their favorable pharmacokinetic profiles. Statins should generally be avoided in acute liver failure and decompensated cirrhosis. Let's briefly discuss pregnancy. Routine practice is to discontinue statins during pregnancy. However, selected patients with extremely high cardiovascular risk, such as those with homozygous familial hypercholesterolemia or established severe ASCVD, may require individualized management. For planned pregnancies, statins should ideally be stopped 6 to 12 weeks before conception. If pregnancy occurs while taking a statin, treatment should usually be discontinued and risk-benefit assessment performed. During breastfeeding, the decision should be individualized. Options include temporarily stopping statin therapy or avoiding breastfeeding if continuation of statin treatment is considered essential. Finally, let's discuss statin intolerance and treatment escalation. When patients are truly statin intolerant or unwilling to take statins, non-statin therapies become important. Ezetimibe is generally the first choice. It lowers blood cholesterol by selectively blocking the MPC-101, Niemann-Pick C1-like 1 protein in the small intestine, stopping dietary and biliary cholesterol from being absorbed. It is oral, inexpensive, well-tolerated, and lowers LDL cholesterol by approximately 20 to 25%. Importantly, it does not increase the risk of myopathy or diabetes. Bempedoic acid is another oral option. It works by inhibiting ATP citrate lyase, ACLY, and preventing the production of acetyl-CoA, a crucial building block for cholesterol synthesis. It reduces LDL cholesterol by approximately 20 to 25% and has demonstrated cardiovascular benefit in high-risk patients. However, clinicians should be aware of potential adverse effects such as hyperuricemia and tendon disorders. For patients requiring more intensive LDL lowering, PCSK9 targeted therapies such as alirocumab, evolocumab, and inclisiran are highly effective and typically reduce LDL cholesterol by approximately 50 to 60%. They lower LDL cholesterol by preventing PCSK9 from degrading LDL receptors. Alirocumab and evolocumab have demonstrated cardiovascular outcome benefits. These agents are particularly useful in patients with a very high cardiovascular risk or persistent LDL elevation despite other therapies. Their major limitations are cost, the need for injection, and access restrictions. Cholesevolin may be considered in selected cases, but is less commonly used because of its high pill burden, gastrointestinal side effects, and limited cardiovascular outcomes evidence. An important modern concept is early combination therapy. Traditionally, clinicians started a statin and waited several weeks before adding another agent. Increasingly, however, early combination therapy is being used in very high-risk patients. For example, a patient presenting with an acute coronary syndrome and an LDL cholesterol above 110 milligrams per deciliter is unlikely to achieve the target LDL level below 55 milligrams per deciliter with statin therapy alone. In such patients, adding ezetimibe during the initial hospitalization is a reasonable strategy. Similarly, patients with very high baseline LDL cholesterol, for example 170 milligrams per deciliter or higher, may benefit from early combination treatment rather than a stepwise approach. Treatment escalation can be guided by the LDL gap from target. If the LDL level remains less than 25% above target, ezetimibe is usually the next step. If LDL remains above target despite statin and ezetimibe, a PCSK9 inhibitor can be added. If a PCSK9 inhibitor is unavailable or not tolerated, bempedoic acid is a reasonable alternative. However, if LDL cholesterol remains more than 25% above target, especially in very high-risk patients, earlier introduction of a PCSK9 inhibitor should be considered. To summarize, statins remain the foundation of LDL cholesterol lowering therapy. Monitoring is straightforward, serious adverse effects are uncommon, and most patients can continue therapy successfully with appropriate management of side effects. When LDL targets are not achieved, combination therapy with ezetimibe, bempedoic acid, or PCSK9-directed therapies provides effective options for further cardiovascular risk reduction.